Hey guys, Kim here, and you are tuned in to Kim E, the Diabetes MP. We are back. For those who don't know, for the month of January, I am going to give commentary over each standard from the ADA standards. That is a lot, but I want to do this. So we'll see how this works. Okay, we'll see how it works. I'm gonna give it my best try. But I've already done the first standard, which was improving care and promoting health in populations. I had to look down because I had put that aside. But today, what we're going to be talking about is the classification and diagnosis of diabetes. Okay, this is section number 2. As y'all see, I have this one's a little thicker than the other one. Okay, so I'm gonna try to move through these a lot quicker. So they're not very long. The last one was 41 minutes and 30 seconds. So hopefully I can get these done a little quicker. But if not, guys, I'm sorry. I'm trying my best. But anyways, like I said, I am going to be able to get through all 17 sections. I am going to post 4 videos a week. Normally I only do 1 video, but I'm gonna do 4 a week. Monday, Tuesday, Thursday, Friday. Okay, we're gonna see how we're gonna do, okay, with this, but let's try it. Okay, so first out the gate, we're talking about the classification of diabetes. And something that a lot of people don't understand is that a lot of times we think about type 1, we think about type 2, and then we think about gestational diabetes. There are some subtypes. They're rare, but our big ones are type 1, type 2, and gestational diabetes. Clearly, the one that houses the majority of people, it is diabetes type 2. And so it talks about what it is, it defines what each one is. So type 1 is due to autoimmune beta cell destruction, usually leading to absolute insulin deficiency. Hence why the treatment there is insulin. It's insulin for type 1s. And you know what? Let me say this, because I work in an environment where we get people that are mistyped a lot, classified a lot. And, me being the diabetes educator, of course, a lot of people, they always kind of default their questions about diabetes to me. And if I see a person who is not on insulin, I'm going to say that's probably not type 1. That's probably not type 1. If they're on any oral medications, that's not type 1. Okay. Now they may have another type, there could be some variations, but there was one particular case, somebody, the person had always been told he was type 1, he was type 1, he was type 1, and yet he never took insulin a day in his life. And I'm like, well, you're not type 1. Okay. And so then we also talk about type 2 diabetes, which is due to a non-autoimmune progressive loss of adequate beta cell insulin secretion, frequently on the background of insulin resistance and metabolic syndrome. Very big lifestyle, right? Like we're very familiar with type 2. And then there are also other specific types due to other causes. So you have your monogenic diabetes syndrome. So this will be your MODY, so your maturity onset of diabetes of the young. So this is like young people. I want to say it's like 25 and younger. I'll talk about it a little bit more and define it. But they don't present as type 1. They present as type 2. And that's where it's the maturity onset of diabetes of the young. That's what MODY is. And then also there is also a neonatal diabetes. There's also an exocrine. This is diseases of the exocrine pancreas, drug and chemical induced diabetes. And then also our gestational diabetes. So we know what that is. That's, when a woman is diagnosed later in her pregnancy, she has to be in her 2nd or 3rd trimester for it to be considered gestational. And we'll talk a little bit about that as well. So out the gate, when it's talking about classification, they're telling us that it's very important to know it's not just enough to diagnose the diabetes. We need to make sure that they're classified right. And that honestly, that a lot of times people are mistyped. You're mistyped. So there are ways and guidance that you can make sure that you have the right diabetes, because that guides what the treatment's gonna be, right? So they do talk about that. Also making like that, though, for the longest, we looked at type 1 as juvenile diabetes. We looked at it as diabetes of the young. Well, that's kind of not the case. And there's some people who get diagnosed later in life in their 8th and 9th decade. And so they do point that out, that you can actually be diagnosed with type 1 later in life. And also on the flip side, we have, because of childhood obesity, we have a lot of children that have insulin resistance, and even some that have type 2 diabetes. And so that's pretty much how it comes out the gate, what we're talking about there. Let's see else. So it's saying that another thing that was very interesting that I wanted to bring up is that it doesn't matter what type they are. Once hyperglycemia has occurred, people with all forms of diabetes are at risk for developing the same chronic complications, although the rates of progression may differ. So typically with your type 1, it's because it's a quick onset. That's the quick onset. With type 2, it's gradual. So that's what they're saying when it's saying that the progressions may differ because of how the disease process is happening there. So normally, if you are diagnosing someone, so for instance, because of type 1 is a quick onset, you wouldn't start screening for complications right away, because complications develop over time. Now with type 2, because that was a gradual onset, and most people have been dealing with some form of hyperglycemia, they've been dealing with the hyperglycemia for some years, you immediately start screening for complications. And so I hope that makes sense. You know what I'm saying? But complications take time to develop. It's not like, so with the type 1, you wouldn't start screening for the eyes. You would, and there's a standard that tells you when we get into the complications, we'll go through that. But like with type 1, because it's such a quick and sudden onset, people are not going to be having neuropathy out the gate necessarily. You know, so they're not going to have that. So the guidelines is not telling you to start screening them and going to a podiatrist every year, every 6 months and stuff like that. But with diabetes, because it's probably been, the process has been happening even prior to the diagnosis, you do need to start screening. And I hope that makes sense. If it doesn't, I can come back on at a later time and kind of explain that a little bit more. Or you guys can wait till we get to the complications. We'll talk about it a little bit more. And so let's see. I think that's about it. They do give us the staging of type 1 diabetes. I don't think that a lot of people know that there are different stages. There's 3 stages for type 1, and the big thing here is that stage 1, really the person can have very normal glycemia. So like, you're not going to necessarily pick it up in a regular blood test. How you would know is if you're doing the autoantibodies, if you're screening for the autoantibodies, that's how you would know. And why would you be screening if somebody has no symptoms? If they have a familiar link, like a family link, it's a genetic thing, because this also talks about that, when someone in a family has type 1, it's like genetic testing because it's autoimmune. And so like, it would be good if you're screening someone, let's say that they have a parent or they have a sibling that has type 1, you could go ahead and start doing autoantibodies testing. And that's how you would pick somebody up in a stage 1. Stage 2 is kind of like the pre-diabetes. It looks very pre-diabetes, right? So they may have some fluctuation in their blood sugar numbers, but they call this dysglycemia. They're still pre-symptomatic though, so you're not going to really see the symptoms. And with just like with pre-diabetes, their numbers are going to be falling into that range. So your fasting blood sugar 100 to 125. Their A1C is 5.7 to 6.5. And then if they do the 2-hour plasma glucose 140 to 199, same numbers for someone that's classified as having pre-diabetes, but this would be type 1. Also, again, the auto antibodies would usually, you would be able to pick up the auto antibodies as well. And that's how you would know it wouldn't be like type 2, is because those auto antibodies. And then of course the stage 3, where a lot of people kind of find themselves, they are symptomatic, they have diabetes per the standard criteria. The numbers are there, the A1C number, it's like they're all class 6.5 and higher, and so on and so on and so. And so that's interesting, something that I find that a lot of people don't know, that there are stages in type 1 as well. Of course, they give the criteria for diagnosing, what that would look like. So of course, your fasting blood sugar is 126 or higher. The A1C is 6.5 or higher. And then the 2-hour plasma glucose is 200 or higher. And I find too, and we'll talk about this, I think is in this one. A lot of people think that 2-hour glucose test, that oral glucose tolerance test, is just, you can only use it in pregnancy. No, you can do that. You can administer that even in your office. The thing about it is, it's not very convenient. That's why we lean to the A1C, because it's convenient. You don't have to be fasting. It doesn't take up a lot of time. That OGTT does. Okay, it's not very convenient for the patient or you in your office. You know what I'm saying? And so, but that is an option if you need it. There are some situations where the A1C is not reliable and you do need to do that. So, but that's that on that. Let's see. I'm just trying to go through. So then we get into talking about the A1C, and it does talk about, and this is what I educate at my 9-to-5 job, is that yes, the A1C is the golden standard, but it's not perfect. It's just not, okay? And when using the A1C to diagnose diabetes, it is important to recognize the A1C is an indirect measure of average blood glucose levels, and to take other factors into communication and consideration that may impact the hemoglobin glycation independently of glycemia, such as hemodialysis, pregnancy, HIV treatment, age, race, ethnicity, genetic background, anemia, / hemoglobinopathies. So there are, in those situations, the A1C really is not going to be reliable. I do work with a lot of people who are on hemodialysis, and their A1Cs run low. They run low. Okay. And so we don't, is so you're not, if they're on dialysis and it was the cause was because of diabetes, it's not an accurate measurement. You see 5.8s all the time and you like, but it's not accurate. It's you have to do something else. Utilize your other tests. Let's see, next page. Let's see, confirming the diagnosis. This is a big one. You do need to confirm your diagnosis. Okay, so it's saying unless there is a clear clinical diagnosis, meaning like the patient is in hyperglycemia crisis, or they have the classic symptoms of hyperglycemia, we know what those are, or you get just a random blood sugar and it's already 200 or higher, then you can go ahead and classify that as diabetes. But if you're not getting that, the diagnosis does require 2 abnormal screening tests, either from the same sample or in the 2 separate test samples. So what I'll tell people is this: most of the time when you're getting blood work, you're already getting a fasting plasma glucose, because you get that with that's in the CMP. So you're getting that already. That's 1. Then you tag on your A1C, that's 2. That's what they mean coming from the same test sample. Now let's say one's abnormal and the other one is not, right? Okay. You need to retest. You need to retest it. Okay. And that's what they're saying. And I think it does give some guidance here. I don't think I highlighted it. I don't think I highlighted it, but it does say that you can use in any of the tests to confirm it. I want to say like whichever one is abnormal though, like if you get two tests and one is abnormal, one is normal, or you need to redo the one that was abnormal. I think that's why y'all need to read it for yourself because I thought I had highlighted that, but I'm sorry. But you do need to confirm the test, okay? And so, anyways, oh, I thought I had saw it. Never mind. I thought I had saw it. But anyways, then we get into type 1 diabetes and what that is, what that looks like. And I kind of already have kind of explained. It goes into like the different types of stages and stuff. So we've already talked about that. And then they do have a type 1 that's called idiopathic type 1 diabetes, which has no known etiology. These individuals have permanent insulinopenia and are prone to DKA, but have no evidence of beta cell autoimmunity. However, only a minority of people with type 1 diabetes fall into this category. So that's one of those rare types. And an absolute requirement for insulin replacement therapy is affected in infected individuals may be intermittent. So yes, so that's that on that. Let's talk a little bit about type 2, prediabetes and type 2. Of course, they give us the criteria for screening people that are asymptomatic. Okay. And I have read this before, but I want to read this again. There are 5 points here. So testing should be considered in adults with overweight or obesity, and they do define what that is, and who have one or more of the following risk factors: a first degree relative with diabetes, you are rather a part of a high risk race or ethnicity, which is African American, Latino, Native American, Asian American, Pacific Islander. You have a history of CVD, cardiovascular disease. You have hypertension classified 140 more than or equal to 140 over 90. Your HDL cholesterol is less than 35 and or a trig level of 250 or more than 250. If you have physical inactivity, individuals with PCOS, or other clinical conditions associated with insulin resistance, severe obesity, acanthosis, nigricans, that is your number 1 point. All of that was just 1 point. Okay. These are the people, and a lot of people fall in this category. So that means you need to be screening them. If they have something, if they are overweight or have obesity, and then one of those points, you need to screen them. People with also, you need to screen people who have prediabetes. So if you've tested somebody and they have prediabetes, they're classified as prediabetes, you need to be screening them too. Or if a person was previously diagnosed with gestational diabetes, they're going to have lifelong screening. Okay, even if they don't develop diabetes, once a woman has been diagnosed with gestational diabetes, she will be screened for the rest of her life. And then it says that also for all other people, testing should begin at 35. Now, this came from last year. 2022 standards is where it changed from 45 to 35. So at 35 years of age, that's very young, everybody gets screened, whether you got symptoms or not. Okay. So they went up 10 years last year, and it's still the same for this year. And then it says if results are normal, testing should be repeated at a minimum of 3-year interval with consideration of more frequent testing depending on the initial results and their risk status. So basically, yes, minimum of 3 years intervals, but if something changes, if their status changes, like they become overweight, they become, have obesity, if a 35-year-old woman at first, you test her, she's 35, she's normal, and then she comes back in 3 years, but she has had a baby, and now she, has gestational diabetes, you will be screening her more. So you just, again, case by case, right? And then also people who have HIV, mainly because of the medications that they're on. I think we're going to talk about that a little bit later. I think that's in this document. So goes into pre-diabetes. And something I want to point out here is that pre-diabetes should not be viewed as, if this is what they say, it should not be viewed as a clinical entity in its own right, but rather as a risk factor for progression to diabetes and cardiovascular disease. It's your warning shot. Pow, pow. It's your warning shot. Okay. So let this be a warning, or not even a warning, because that seems so ominous, but like this is your like, hey, your harbinger of like, we need to do something here. Okay. And it says the presence of prediabetes should prompt comprehensive screening for cardiovascular risk. Now, years ago, we did not really talk about the cardiovascular risk when it came to diabetes. It was almost like each one was just dealt with isolated. And but it's saying that no, you have prediabetes, you're not at risk for cardiovascular disease. Actually, on this page with the criteria for screening for diabetes or pre-diabetes in asymptomatic adults, that's one of the points. If a person has history of CVD. So of course, they give us what the criteria for prediabetes is. I already kind of talked about that when I was talking about the staging. Same thing, for the staging for type 1. We've already talked about that, but they do give you guidance there. They also give you guidance on screening children, type 2 and prediabetes and asymptomatic children. There's a chart, a box there as well. And then we get into type 2 diabetes, which accounts for 90 to 95% of diabetes. So the majority of people that have diabetes have type 2. Okay. They do include the risk. This is on their site as well. This is on their site. Are you at risk for diabetes? I filled it out for myself. I am not at risk. I have a very low risk. But what puts me up is the fact that I do have a family member. It says the question that says, do your mother, father, sister, or brother have diabetes? Well, my mother has diabetes, so I had to give myself a 1 there. And then, have you ever been diagnosed with high blood pressure? With both of my children, I had preeclampsia. With the second child, it lingered a lot longer, past the 6 weeks. And so, yes, I have had that, and that also runs in my family. My mom, my sister, my dad. Yeah, a lot of people in my family have high blood pressure, so I'm at risk for it. And so, but outside of that, those are my only risks. So I only had a score of 3, which is really good, because if you scored 5 or higher, you are at increased risk. I'm at a 3. And so it's a really interesting tool. It's something that you can, like, when you're screening your patients, once they meet those criteria, you can have them fill this out with all the paperwork that they have, that you do with your office. Let's see. It talks about how many people go undiagnosed for many, many years because hyperglycemia develops gradually, and at the early stages is often not severe enough for the patient to notice classic diabetes symptoms caused by hyperglycemia, such as dehydration or unintentional weight loss. So that is, why they give us criteria for screening. Also, it says that people may have insulin levels that appear normal or elevated, yet the failure to normalize blood glucose reflects a relative defect in glucose-stimulating insulin secretion. Thus, insulin secretion is defective in these individuals and insufficient to compensate for the insulin resistance. And so, so it talks about that. All the more reason why we need to lean into, like, people who are at risk, early detection, early screening. It says that, let's see, approximately 1/4 of people with diabetes in the US and nearly half of Asian and Hispanic American people with diabetes are undiagnosed. That's mind-blowing. 1/4 of people. And then half of 2 cultural groups go undiagnosed. And I got to thinking to myself, I wonder why. I wonder why. Why is there such a big difference between those groups and everybody else? I wonder why. So I mean, what are y'all's thoughts? What do y'all think that's attributed to? And so it points out that age is a major risk factor for diabetes. On this risk right here, if you are older than 40, like once you, it says, how old are you? If you're less than 40, you gave yourself 0 points. If you were 40 to 49, you gave yourself 1 point. If you were 50 to 59, you gave yourself 2 points. And then if you were 60 and older, you gave yourself 3. So as you get older, your risk increase. And it reflects it here. Okay. So that was interesting. You know, you can be very healthy, but as you get older, you can develop diabetes, and that can be your risk factor. And so it talks about certain medications can cause or increase the risk of diabetes and should be considered when you're thinking about your treatment options. And so we go into HIV. And so here's the thing about HIV. So the medications, and I'm going to read to you the different types of medications and why you need to screen those who have HIV. So let's get in here. It says individuals with HIV are at higher risk for developing prediabetes and diabetes on antiretroviral therapies, ARD. So you have your PIs, and they are associated with insulin resistance and may lead to apoptosis of pancreatic beta cells. And we see that's a problem. And then your NRTIs are also, they also affect the fat distribution, which is associated also with insulin resistance. So that's what's happening there. There's a cause for insulin resistance. And so then let's see, we move over to cystic fibrosis. And it says that annual screening for cystic fibrosis should happen with an oral glucose tolerance test and should begin at age 10 for all people with cystic fibrosis. And there is a cystic fibrosis related diabetes, and it's the most common comorbidity in people with cystic fibrosis. I think I remember when I first read that years ago, I didn't know that, you know. There's insulin insufficiency is the primary defect in CFRD. And then in this situation, you would not use an A1C, you would use an OGTT. This is the recommended screening test, and the A1C is not recommended. And also with cystic fibrosis related diabetes, insulin is the most widely used therapy here. Okay. Let's talk a little bit about post-transplantation diabetes mellitus. I actually had a very interesting exchange with a coworker, because again, like I said, I work with patients that have dialysis, and so some of the patients have had kidney transplants, and we still manage patients and things like that, even in that. And so there was a nurse practitioner that had a question about the diabetes treatment, and I was pinged in on the conversation because I'm the diabetes educator. So here's the thing that a lot of people don't know, and I'm going to read this off, and this is what I shared with her as well. You can have a new onset of diabetes after transplantation, okay? And it excludes people with pre-transplant diabetes, though, okay? So these are people who were not, this is people who don't have it prior to, okay? And it says it excludes people with pre-transplant diabetes that was undiagnosed, as well as post-transplant hyperglycemia that resolves by the time of discharge, okay? So hyperglycemia is very common during the early post-transplant period, up to about 90% of a kidney allograft recipients exhibiting hyperglycemia in the first few weeks following the transplant. In most cases, though, such stress or steroid-induced hyperglycemia resolves by the time of discharge. And so you really cannot diagnose them with that until and you can't diagnose them with that until you rule out all these other factors. It also says this is a situation where you would use the OGTT as well. For testing, it is considered the gold standard, and insulin therapy is the agent of choice for managing this as well. And I want to say there's a part here that I wanted to say. Let's see. I'm gonna see. So you do. I want to see a formal diagnosis of post-transplantation diabetes mellitus is best made once the individual is stable on an immunosuppressive regimen and in the absence of acute infection. Here's the reason why. When we have infection, our body is on fire. You are going to have high blood sugar. So you got to rule out all this other stuff because that's what's causing the hyperglycemia. Once they're on the immunosuppressive regimen and they're not in active infection, have no active infection, then that's when you can make the diagnosis with the OGTT. And then it gets into our monogenic diabetes syndrome. So I mentioned one of those is the neonatal diabetes, which occurs under 6 months of age and is termed the congenital or neonatal diabetes. And it says it accounts for about 80 to 85% of cases can be found to have an underlying monogenic cause. And then we get into the maturity onset diabetes of the young, or MODY. It's frequently characterized by the onset of hyperglycemia at an early age, and like I said, classically before age 25. MODY is characterized by impaired insulin secretion with minimal or no defects in insulin action. So there are different types of MODY, and depending on what type it is, which it gives you guidance here, and this up here gives you guidance of how you determine which type it is. Depending on what it is how you gonna treat it. And some of them have no treatment, So in MODY, I think there's one that is no treatment. Also here, OGTT test. So OGTT, I say OGTT test. Then it talks a little bit about the pancreatic diabetes, or diabetes in the context of disease of the exocrine. Very small subject section here, and then we get into our gestational diabetes. Something I wanted to point out here is that they define it as any degree of glucose intolerance that was first recognized during pregnancy, regardless of the degree of hyperglycemia. And this definition is more uniform because it used to be if a woman has diabetes in pregnancy, she has gestational. But no, they now know that there are women who, have pre-existing diabetes but have not been diagnosed. So that's why it has to happen. The screening happens in the second and third trimester. And then, of course, they give the screening for and the diagnosis of gestational diabetes. You can do the 1-step or you can do the 2-step. I did both. I think with my first child, I think I did step 1. Yeah, because I was fasting. With my second child, I did the 2-step because I was allowed to eat. And you do this at 24 to 28 weeks. So the woman is 6 to 7 months. And that's when you'll have this test. So yes, I was fasting the first time, but I wasn't fasting the second time. So I've had both. I passed both. That's not one of the things that I have had to deal with. And I'm glad and grateful for that. And what did it say here? It says that the ADA recommends that the diagnostic criteria with the intent of optimizing gestational outcomes, because these criteria are the only ones based on pregnancy outcomes rather than endpoints, such as prediction of subsequent maternal diabetes. And so That's pretty much it. I think I went through this one a lot quicker, few minutes ahead of the other one, but this was a pretty thick one. Okay. Like this one was probably the longest one out of the ones I've read so far. There's some more coming. But this was good for classification and good guidance for diagnosis. And so, anyways, guys, tell me what y'all think. What do you think about this? Any questions at all? Drop them down in the description box. I will link this one as well, this direct one. I'll link that for you guys if you want to print it off for yourself, read it, or read it read it just online or whatever. I'll link that for you as well. But you have been sitting here with Kim E, the Diabetes NP. I'll catch you on the next one. Bye.